There are a few important factors we need to take into consideration here. So we're laying the groundwork of, and that's why it's called guides. We're learning what the guides are right now. These are the guides. Remember, they're not rules, they're guides. They're interpretive. And the reason they're guides is because there can't be a book that's made that has every specific disease known to mankind. So that's why they're called guides, not rules. So your interpretation is going to be very important, and how much you use the guides with your interpretation is going to be a major factor in your credibility with given impairment ratings, especially if you're doing a trial testimony. So having said that, says the physician should personally review the studies and report agreement or disagreement with previous interpretations. That should be an obvious statement. Positive imaging study in and of itself does not make the diagnosis. Now that's very important. Again, just because you have a positive finding doesn't mean you have that diagnosis. Now, the reason I say that is a lot of the injuries we deal with are spinal ligamentous lesions. And so a patient could have let's say they could have a MMI. Let's say an MMI, they have a ligamentous lesion, but they have no symptoms and it's not affecting their activities of daily living in any way. Well, you don't have much of a case. That's essentially subthreshold. Because remember, there's a lot of injuries, small injuries, that are permanent, that are subthreshold. And again, what does subthreshold mean? It's not affecting your sensory or motor in any shape or form. When I give seminars, I always point this out. I have a couple scars on my thumb from scuba diving. I remember running into some metal and scuba. So I've got some visible scars on my thumb. Well, is it a permanent impairment? Well, it's permanent, that's for sure. Well, it doesn't affect sensory motor. It doesn't affect range of motion. Thumb still got good range of motion. I got good strength. I've got good sensation. Reflexes are normal. Okay. In other words, it's not affecting any of my senses, and I can fully do activities of daily living that are relative to my thumb. So even though there's a permanent injury here, it's not of much value because it's subthreshold. So be highly aware of that's why it's so important when you're doing your clinical diagnostics that you pay a lot of attention to what I call high sensitivity, high relevancy diagnostics. If you do what's called low sensitivity, low relevancy diagnostics, a lot of your tests will be false negatives. They'll be negative, but you didn't do the test right, because if you did it right, it would be positive. So that happens a lot, especially with range of motion doctors who only check range of motion, reflexes, and dermatones. You're pretty much, those are like the worst test for a low impact soft tissue spinal injury. They'll almost always be normal. So having said that, clinical findings must agree with the imaging findings. Imaging results alone are insufficient for the DRE category. So that's real important. Imaging results alone are insufficient for a diagnostic related estimates category. Okay, so individuals, okay, let's go. All right, motion, segment, and timing. So now we're getting into some of these categories that are real important to chiropractic for the low impact soft tissue spinal injury. So here it says a motion segment of the spine as defined as there's some really key important phrases and words we're getting ready to move into right now relative to the low impact soft tissue spinal injury that we typically see as chiropractors. All right. So it says a motion segment of the spine is defined as two adjacent vertebrae, the intervertebral disc, the apophyseal or facet joints, ligaments, structures between the vertebra. In other words, we're talking about a motor unit here. Now that's going to be, in other words, we're going to evaluate a motor unit. We're not just going to look at gross range of motion. It's specifically saying motor unit. That's what it's saying. Okay. This is going to be real important with the diagnostics of low impact soft tissue spinal injuries and impairments. And then it goes in to talk about some of the motion with the motor unit, talks about upper cervical spine, occiput to C2 is very little flexion extension. So it is good to have a general awareness of some of these motions because we are going to be looking at them. Some of them we're going to measure. And so it says flexion extension movements from are about 10 degrees at C2 to C3. So there's less movement at C2 to C3 to about 20 degrees at C5 to C6. So there's much more flexion extension lower than upper. And then C6 to C7. So flexion extension movements are about 4% in the upper thoracic spine, 6% in the mid thoracic, and 12% in the lower. Okay. We already know there's not much motor unit movement in the thoracic spine. Lumbar spine, it's a gradual increase. So about 12 degrees at L1 to L2, up to 20 degrees at L4, L5. So that's just good general knowledge, okay? We're going to have to get a little more specific with that, though. And it talks about lateral bending in the lower cervical spine, 5 to 6 degrees, 6 degrees in the upper thoracic spine. Lateral bending is greatest at L3 to L4. It's about 8 to 9 degrees. Axial rotation is 30 to 40 degrees in each direction. Okay, so just generally speaking, it's just good to know the upper neck doesn't move as much as the lower neck, et cetera, et cetera. Okay, so we'll go into there are some numbers and details you definitely need to be aware of, and we'll definitely go into those and point those out. All right, so it says the spine movements are coupled. This is very important right here. The dominant motions at both the lower cervical and entire lumbar spine, where most clinical pathology occurs, are flexion extension. And you'll notice I not only underlined it, I wrote next to it, I said not exclusive. This is very important. It says the dominant motions at both the lower cervical and entire lumbar spine, where most clinical pathologies occur, and I would agree, it says where most flexion extension. It does not say all, and we're only going to pay attention to flexion extension. That is not what that says, okay? That's going to be real important when we start doing these evaluations because a lot of our injuries are not in that category. All right, so it's not exclusive to, that's the point I'm trying to emphasize here. So we're talking about motor units, and it's not exclusive to flexion extension. However, that's where the majority of the injuries occur, okay? So it says alteration of motion segment integrity can be either loss of motion segment integrity, increased translation or angular motion, or, and this becomes very important, decreased motion resulting. Now that's the key. So when we talk about altered intersegmental spinal motion, it could be increased or decreased. All right. Very key, major point right there when we start doing our soft tissue injuries. Now, obviously, most of the time when we're dealing with increased motion, we're talking about ligamentous lesions. Now, when we talk about decreased motion relative to the low impact soft tissue spinal injury in chiropractic, now this says mainly from developmental changes, fusion, fractured healing, healed infection, or surgical arthrodesis. Now, when we see decreased motor unit in a chiropractic arena, now this says mainly, that's not typically what we see it from. When we see decreased motor unit, what's it typically from when we see it? It's from fixations. It's from the collagen. We know in the science of the 3 phases of healing that the collagen is only 70% as strong and 70% as elastic. So what does that mean when we do motion studies and the patient's healed? We're going to see decreased motion in that motor unit. So this becomes a very important understanding that we are not just talking about gross range of motion. We're talking about a motor unit and the associated tissues, ligaments, muscle, capsules, joint, facets, disc. These are going to become very important factors. Okay. And it says healed. The key word it's saying here, it says healing, healed infection, healed. Well, guess what? It also includes healed from healing based on the science of the 3 phases of healing. Well, we all know as chiropractors, we see fixations routinely. People who have injured themselves, they've healed wrong. We'll do a motion study in the neck and we'll go, whoa, there's some serious abnormal pathological restrictions here. We see that all the time. Well, that's inclusive. This is part of the impairment rating scenario. That's why I'm emphasizing this right now. So it's not just talking about ligamentous lesions with excessive motion. It's also talking about decreased motor unit. And from our perspective, like here it mentions healing or infection. Well, with our perspective, it's from the science of the three phases of healing and injury due to collagen only being 70% as elastic. Major effect.